Good morning, good afternoon. Welcome to the Millbank Memorial Fund virtual seminar for January of 2021. I'd like to welcome all of you who are here. We have about 50 people on the line. We're going to be getting started in just a few moments. I wanted to just go over a couple of just technical pieces. We're obviously just admitting people to our meeting. So please, I thank you for your patience. And my plan had been to have everyone introduce themselves on the line today, but because we're expecting close to 100 people, I think we're not going to be doing that today. So I'd like to prevail upon you to quickly just make a quick note in the chat function, which I'm sure you're all quite familiar with. Just write a quick hello with your name and your organization. We're delighted to have you with us, and we'd love to have the opportunity for everyone to see who's on the line with us today. So just wanted to go over the agenda briefly. As I said, the title of today's meeting is Addressing Social Determinants of Health and Their Impacts. And we're looking at philosophy, really an approach that various organizations have taken, tools, and how to have this be a sustainable process. We have a 3-hour event. I recognize many people don't have that kind of time in their day, but thank you for joining us for whatever portion you can. And with that in mind, we are recording this meeting so that all of our presentations and the discussion will be available posted to our website with a YouTube link to be able to watch the video recording within a few days of today. In addition, we'll have very brief summaries. So if you have colleagues that were unable to join us today, or you're unable to keep us stay with us for the whole time, the opportunity will be there to listen in. So with that, let me do a quick welcome to our speakers and just sort of the run of the show today. We have members of the Idaho Health Data Exchange who will be describing their work looking at social needs and how that's seamlessly integrated into their health information programs, as well as Jill Weeks, who will be with us to describe some of the use of that in their state. We have a 10-minute break at 1 o'clock. I would beg you, please don't sign out if you plan on staying for the rest of the meeting or some portion of it. If you sign out, your chat will be gone, and you won't be able to see what other people have been asking or see who's here at the meeting. So if you're going to leave, just don't sign out. At 1:10, we'll recommence, and we'll be learning about social determinants of health screening, outreach, and delivery on the ground in Ohio. And we have our colleagues from the Health Collaborative there, as well as CareSource, describing the types of interventions they've been using in terms of their technology, identifying patients that really need resources and how to get them connected with the resources they need. We'll have another 10-minute break then, same deal in terms of if you're not leaving for good, please don't sign out. And then at 2:05 on the dot, she says, hopefully we'll commence with our third presentation from the team at MyHealth Access, who will be describing their Oklahoma Route 66 Consortium program, which is a mobile social needs screening. Thanks to everybody who's been signing in on the chat. Great to see all of you here. And thank you so much for being a part of this today. We're really delighted to have all of you on the line, and we'll get started in a moment. One other just housekeeping note, we will be doing these presentations. This is a very relaxed situation. Obviously, that our speakers are happy to entertain questions. We're leaving plenty of time at the end of each of the sessions for that. But we will be also, if you really have something pressing that you want to make sure that we address, please put a question or a comment into the chat. We'll be monitoring that so we can keep that side of the conversation going. And if you feel that you really need to ask your question out loud, feel free to unmute yourself and ask your question and interrupt to do that. I think we can handle that level of discourse and really look forward to that. Anybody have any questions or concerns? We're all good here? Great. Okay. So with that, I would like to take the opportunity to introduce our first panel of speakers. We have with us representing the Idaho Health Data Exchange, Hans Kassensmith, who is the executive director of the organization. He's a five-time CEO with many decades of healthcare experience and has participated in significant reform initiatives in healthcare, in government, and the private sectors. He has successfully helped to shape healthcare policy at the federal level with Congress and served as the subject matter expert in many environments. And Hans and I go way back to his time in Vermont, and I'm very delighted to have him here. Laura Nixon is also joining us. She is the product manager for the Idaho Health Data Exchange, which is under contract with Brilliant, a leading healthcare consulting firm. She's a member of the Technical Advisory Committee member for the Gravity Project, which sets data standards for social determinants of health. So obviously this is, has brought a huge amount of her expertise to this process. So we're delighted to have Laura with us. And finally, we have Jill Weeks, who is serving as the Executive Director of Transitional Care Services for Kootenai Health, a 300-bed community-owned hospital serving patients in northern Idaho, eastern Washington, Montana, and the inland Northwest. She's responsible for administrative and operational direction of care management across the continuum. So with her very diverse experience, she's going to be sharing that with us today. So what I'd like to do is hand over the controls, I believe, to Laura. Laura, you can share your screen, and if there's any issue, we will share it from here.
Okay, and I'll start sharing just as soon as you're done.
I am done.
Well, you just click the button.
I'll stop sharing.
There you go.
That would make it better. I was done, but it wasn't obvious.
It's okay. There we go.
Thank you, Laura.
No problem. Are you guys able to see my screen that says IHD Spotlight on Social Needs?
Yes.
All right, great. Well, just a quick agenda check-in here. We're going to spend about 5 minutes doing an overall introduction of the Idaho Health Data Exchange and essentially just some of our inner workings and our vision and mission and our process behind integrating social determinants of health within our technology services. We'll spend about 10 minutes talking about a social needs story just in the capacity of working through a closed loop referral platform. And then finally, we'll spend some time on real world experience. And that's when I'm going to pass it over to Jill, who will talk about her experience with social determinants of health out in the real world. And then finally, we'll spend some time doing discussion with you all at the end of the 45 minutes there. So I'm going to turn it over to Hans to get us started.
Hello, everyone, and Lisa, thank you for inviting us and to this to the webinar today. And wow, what a turnout! This is great. Love to see this much interest in social determinants of health around the country. We've been, working with it for the last 20 years, really, in healthcare, and I'm just really glad to see it coming to the forefront now. IUCE last year our team came in to start on a 2-year modernization project of the Health Data Exchange, expanding our partnerships across the state, building a much larger group of folks that are joined into our network, and expanding our offerings to be able to put out shared services to support the efforts of lowering the cost of care and raising the outcome levels of it. And so, Laura, if you go to the next slide, we've been integrating with a wider group of facilities like skilled nursing, emergency response services, behavioral health, addiction centers, and even down to homeless centers. Around the core of the first year that we really wanted to get finished was to bring this shared technology services platform, what we lovingly call a super stack, up to reality so that we had the capabilities from a technological standpoint to support the programmatic approaches that we wanted to go after. And so we stood up a new, what we call Lake on Fire, which is a fully fire-based data warehouse. We brought in Formedica to improve our patient matching. We were in not very good shape with that, some 30% mismatch. Now we're down to under 1%. Orion Health being our primary exchange capability, but we've done a lot of work on its presentation of data through our provider portal. We've upgraded on alerts and notifications, and we've set up a telemedicine network with MyHealth, which is a free platform. We brought in KPI Ninja to be able to do advanced analytics, which is tied to the rest of the stack. Connect America to be able to do remote patient monitoring. That's fully integrated into our systems now and makes things like that very easy. And then to the subject at hand today, we did a statewide license with Aunt Bertha, our social determinants closed loop referral platform, to bring that out and make it available to the entire state. When we first started this and made this plan to bring IHD up to the new standards of support from an HIE to its community, really social determinants took a front seat in what we were trying to accomplish. We feel that data from a number of different sources supports our ability to be able to help our communities, but most specifically, one of the biggest lacks, of course, is always how do you find the resources to help individuals who have special needs and be able to get them referred in there and watch that it happens and complete the entire circle to ensure that level of care is being delivered. And so we did a nationwide search with a number of platforms, and there are a lot of great ones out there, no question. Aunt Bertha was the one we ended up selecting, and that team engaged with us to establish, I think, one of their first statewide licensing strategies with an HIE in the nation. And IHD is fortunate enough that we've just received a major grant from a private fund that's allowing us to actually pay for all of this without having to raise our pricing and to the community, and actually truly be able to offer this as a shared service without the burden of having to figure out how to pay for it. And what that approach really affects is our smaller practices throughout the state, and we're a very rural state with very many practices that are disadvantaged, have high workloads, have patients living very far from their practices. And so access to these services plus access to the services that we can refer to through Aunt Bertha became extremely important. And we did not want to put the burden of how do I pay for all this. So in essence, we're bringing a very advanced technology stack to places and people that really could never afford this type of fully integrated technology services. So I'll stop with that and let Laura get into the social determinants of health storyboard. Laura?
Thank you very much. Social determinants of health are near and dear to my heart. As Lisa mentioned, I'm on the Gravity project, and I think one thing that we've determined over the course of the last couple of years is that people have different variations on how they talk about social determinants of health and social needs. And really today, I just wanted to spend some time putting together a little visualization of what a patient's experience is with this closed loop referral platform that helps mitigate their social needs and address those gaps in their life that may be affecting them in other capacities. So we all know that your total health is not just at your doctor's office, but 80% of it is affected from other situations. And so with this story, we can just kind of talk about Janelle, our patient here, and understand what workflow is through this process with this closed loop referral platform that we've been able to offer to all of our participants and all of our community-based organizations as well. So as we move on, meet Janelle. Meet Janelle. She has diabetes and she lives in Preston, Idaho. Janelle's condition requires careful monitoring and coordination between her primary care physician, Dr. Smith in Preston, and her endocrinologist, Dr. Jones in Pocatello. Both doctors and their clinics are connected to the Idaho Health Data Exchange. And so let's get started. In our instance of Aunt Bertha, we utilize the PREPARE assessment. And if you're not familiar, which I assume most of you are, the PREPARE assessment is a national effort to help health centers and other providers collect the data that they need in order to better understand and address their patients' social needs. So this form is very simple to understand. It's very simple to walk through. And in this instance, at Janelle's most recent appointment, she completed the PREPARE assessment with her social worker. They walked through this assessment and entered all of the pertinent information. And because of that, we realized that Janelle has some social needs in the areas of access to quality healthcare, access to nutritious food, access to reliable transportation, access to social support, access to safe housing, and access to education and health literacy. So all of those different social needs play a role in Janelle taking care of her chronic condition and managing those different aspects of her diabetes in order to stay compliant with her medicine, with her doctor appointments, that type of thing. So because the PREPARE assessment was able to identify those specific areas of needs, we realized that there's a multitude of different community-based organizations out in the world that could potentially fit those needs, right? So the PREPARE assessment allows the Aunt Bertha closed loop referral platform to essentially categorize the social needs based on taxonomy. So what we're able to do is select the different categories based on what Janelle needs in order to fill those gaps. So you can see here on the screen that the food category, housing, transit, health, money, care, education, and work are all highlighted. So those are all areas where we can explore and determine if we can help Janelle better take care of her social needs. We're able to filter these different community-based organizations based on zip code or keyword, program, that type of thing. So if you specifically wanted to focus your attention on transportation or specifically Lyft, you could type in Lyft and it would give you that community-based organization program card that has all of the information that you need in order to reach out to that community-based organization to start that referral process. So we have a couple of different graphics on this screen here, and the program card that I was talking about is right here down in the right corner. That program card has different pieces of information that you can expand on, whether or not you want to save this for a future reference, whether you want to put in notes specific about Janelle, you can do that, or you can share this program card directly with your patient, or you could share it to the community-based organization in order to actually instigate that referral process. So just speaking about that actual closed loop referral process, we are going to kind of walk through it in steps here. So Janelle has been referred to the community-based organization, or CBO, based on her social needs. That CBO receives the electronic referral, and Janelle, then that CBO then reaches out to Janelle based on her communication preference. And we're able to determine which communication preference she has based on this card here. You can update it, email, text, phone, that type of thing. You can add your comments here if you wanted to say, you know, Janelle would like to talk to you about your services, but she is hesitant, so it may take her a while, that type of thing. So once Janelle has determined that she does want to meet with that CBO, she meets with them to address her concerns. The CBO is either able to help her or help her get to the right community-based organization that she does need. And at that point, that referral is completed within Aunt Bertha, and the goal is documented as done. So at this point, you might notice down here that we have an area that is confirmed consent. And this is an overall consent that the person that is helping them with this organization or this community-based organization referral has their verbal consent to send this information. So that is required, and I just wanted to quickly point that out. Right.
So Laura, I'd also just add here that in looking at what has to happen in a clinical setting with very few people and smaller practices and such, to be able to accomplish something like this in the normal world without any kind of systems automation, you would have to, you know, take the patient's information in on the form from the prepare form, which would be on paper essentially, or maybe in your EMR, but that data would sit in your EMR, it wouldn't be active. This allows us to activate that information against a set of already categorized and cataloged resources out in the field, and do all of this automatically, as opposed to having to pick up the phone, make a bunch of phone calls to find out whether or not there's, you know, what the program might be and if it was in support, and then contact the patient and deal with the referral, and then get them referred and not be able to track it afterwards to see what happens. So this, you know, in talking to folks in the community, and I think Jill will be able to support this, this takes away a huge amount of workload for the practice and allows them to do something automatically, very quickly and very efficiently to be able to initiate a care episode. Go ahead, Laura.
Yeah, and to augment that, Aunt Bertha really pays a serious focus on maintaining those community-based organization relationships. So they are actively, excuse me, they are actively working to confirm those relationships on a regular basis, updating the program cards with specific contact information, hours of operation, if they've moved, that type of thing. So they're a really solid partner when it comes to maintaining those engagements within the community, because as we all know, it's very difficult to maintain a manual list and ensure that it's updated regularly and validated. So we've been really working with our folks that have been assigned to us at Aunt Bertha to form a statewide collaborative effort in maintaining those community-based organization relationships. And we're really expanding our efforts in a lot of different ways by looking at it from a perspective of, if we create a collaborative or a consortium, this group that has the same focus, we can decrease each other's workload and improve the quality of information within all of our Aunt Bertha enterprise instances. So it's been a collaborative effort to maintain those community-based organizations within Aunt Bertha. All right, so once those referrals have been completed, or even as they are hanging out, the person who is able to, or that is helping the patients, whether it's a care coordination team, whether it's a social worker group, whether it's the state Medicaid office, that any group that has access to Aunt Bertha is able to perform analytics based on their searches, based on their patient population. You're able to track your patients' goals to ensure that they are hitting them. If they're not hitting them, you're able to make notes, change their status, and really kind of track them at a more granular level so that they don't just fall off the radar. Because that's, one of the things that, as we were searching and coming up with our requirements and our needs for this platform, we realized that, it's not just about showing what needs are there, it's about getting those needs met and then ensuring that they've been met. And if they haven't been met, tracking them to follow through and understand why it didn't work, how we could do to improve that in order to improve outcomes on a more, like I said, granular level. So that being said, because of all of that focus on those social needs, we're able to improve Janelle's opportunity for better outcomes. So she has more access to nutritious foods to improve her diabetes control. She has access to safe and secure housing, access to educational resources to improve clinical decision-making, improve coordinated care among providers, and reduce unnecessary hospital visits and diagnostic testing. That utilization really starts diminishing there. So access to reliable transportation. So it really is a holistic way to address a patient's social needs and really follow them through to final outcome. And so that being said, I just want to be really cognizant of time. I am going to pass the mic to my colleague, Jill, and let her talk about her experiences with social determinants of health in a real world setting.
Okay. Good morning. Can you hear me?
Yeah, you sound great.
Yes.
Okay, good. Thank you for the opportunity to share our experience at Kootenai. We, as part of our population health strategy, we did recognize that social determinants of health play as critical a role in
at the same time.
Utilization of services, their well-being as clinical indicators. As we assessed our community resources and how our care management team and our social workers were accessing those resources or identifying those, we realized that we had outdated spreadsheets, we had binders full of outdated brochures. We were accessing multiple directories that had segments of community resources, but it wasn't a comprehensive source. And so we wanted to create a comprehensive database that put resources that were available in our region at the fingertips of our care coordinators and our social workers. And so we pursued some different vendors as well and selected Ambertha as our partner. We did include our community partners that are part of our network of our population health that we meet with on a regular basis, and they helped us select the vendor. We wanted their engagement as well because we wanted as many people using this resource as possible and making sure that we were populating it with all the resources, especially resources that don't typically fall on national databases like the free and reduced services, but maybe a local church has a food pantry or parish nurses or clothing or peer support, those type of things. We want to be sure were captured in our database as well. Over the last year, we've mainly been working on the structure of the database, and so making sure that we have a comprehensive database. We've been educating all our community partners in collaboration with Ambertha on the tool, educating them on how to claim the site and optimize the site so that when we are using filters to search for resources, that the tag words are ones that we can quickly access and identify those resources that we most need. We've done a lot of education as well with our staff on how to optimize the program to create their favorites and folders that they can share, or how they could print off a list of resources for a patient. GPS resources, GPS is also included, that really helps identify where the resource is so that we can direct patients to that resource. We've even used that functionality with our Total Joint program, where we've created a map of all the DME resources that we can refer patients to as well. The purpose, one, is to have a comprehensive database that's at the fingertips of our resources, our team members, to streamline that referral process. We also wanted the database to be able to track gaps in care. So when we were looking at all the directories and the resources that different community partners were trying to maintain, we said, let's use a single source for our community and our region, and then you guys can reallocate the time that you're spending on trying to maintain your database and use that to fill some of the gaps in the community that we have needs for. And so part of the strategy was a community-wide effort to streamline work that many different organizations were trying to do to maintain their own directories, centralize it, and then optimize other resources to fill those gaps. And so the gap analysis is helpful for us to see where those holes are and then work with our community partners. I will say the closed loop referral is a critical piece of this database, and it's one that we haven't fully optimized yet, but we are piloting we decided to break down some of the resources to focus on a closed loop referral process, because in order for a closed loop referral process to work, it requires the community-based organizations to have resources available to accept those referrals, document what happened with that referral, and partner with us. And so we wanted to break it down into different focused areas. And we're going to start with behavioral health and mental health resources, because we know that that area is one where we may make a referral, but the follow through and the likelihood of our patients actually accessing those services are a very low percentage. So we thought that was one area where we could have the greatest impact with that closed loop referral, ensuring that our patients are connected with those behavioral health and mental health resources in the community. As far as our social determinants assessment, we are currently using just a modified version of the health leads assessment, which is very similar to the Prepare that's in our Meditech system, we're transitioning to Epic. And with that Epic transition, we'll be considering the Prepare as an assessment. And then Epic does have an interface with Aunt Bertha, and so that we can have that integrated within our system. And both our inpatient, outpatient social workers and care managers will be able to see what's been set up for patients as far as community resources. So that's kind of the highlight of it. We're still looking for ways to optimize the structure, but it's really been a valuable resource to identify resources in the community. It's been a great community partnership to get other community members using it as well. And then even with the COVID, it's been a great resource. So as different agencies were not able to do their typical service, and they changed gears, and maybe we had an adult respite organization that had to close as far as having patients come in for respite, but instead they provided delivery for medications and groceries. And so they wanted a way to get that information out. And so we created a special COVID section on our Aunt Bertha page so we could direct patients to COVID-related resources, whether it's medication pickup, groceries, financial assistance, child care, a number of different resources that were really helpful for our patients. Any questions?
Jill,
So, Jill,
that's great.
go ahead.
Thank you very much. I just want to make sure just a quick note that people have been putting questions into the chat, so we'll address those in just a few moments. And Hans, it sounded like you had something else to add.
No, I was just going to add quickly the flexibility of a platform like this. So even as we are looking at just rolling it out as Aunt Bertha stands today, there's been another request from some partners at the Idaho Primary Care Association to look at a closed loop referral for dental programs for people who are underserved or may not have insurance. And so we're looking quite possibly to use the capabilities of Aunt Bertha to put another closed loop referral system up for those types of assets. So it's ultimately flexible, and we think that it can expand to a number of different things that it may not have been originally meant for, but kind of follow the same pathway. And so anyway, it was a great choice, and I know there's other great choices out there, but we're really happy with what we have here and the future for what we can do on a statewide network here. We're following a lot of Kootenai's leads. They've been at this for a couple of years, and it's invaluable to understand how it worked out in a particular network, and where we can go from lessons learned there and wider systems integration as folks like Jill's organization switch over to Epic, and it's already offered in there. We are still going to be able to integrate the back-end information so that we can trade it and offer it back out to folks who may be serviced outside of their network. And I'll end there.
Great. Laura, did you have anything else you wanted to add before we move to the Q&A?
No, I don't think so. I saw some really great questions. So
yeah, there's some really great questions.
Yeah,
so I'll just sort of, I've been monitoring the chat, so I'll start asking these. And I think some of them have been addressed because they were asked a little earlier on in the presentation, but specifically around, first of all, just a nice comment, a great statewide strategy. And it's very exciting to have our colleagues from Idaho join us. Idaho is not part of the CPC Plus, which or Primary Care First, that many of you are representing, but obviously doing some amazing innovative work. And so thank you so much for your willingness to share your experience with us. So one of the questions was around the closed loop referral and whether that includes patient preferences, and specifically about Aunt Bertha or Prepare having a question about a desire for assistance. So essentially a readiness type of question. So I don't know if anybody wanted to address that.
That's a great question. And to be honest with you, I don't know that I have the answer to that. Hans, I heard him, he may have the answer, but I guess our thought is that we are providing this technology to the providers and we're allowing them to make that decision. And if it's a question within the prepare assessment, then yes, but other than that, no.
Yeah, Laura, I don't know whether or not there is a question of prepare assessment around that, but I did answer this a little bit that, you know, this is in front of the provider. So having the enterprise version of this is directly for the provider to, now while there is a patient self-referral capability, this is for a time for a provider and a patient to work out this issue together. Opt-out would happen right there. So if it's, you know, their physician or a different type of a different member of their health team, that would be discussed, you know, with the provider and whether or not a referral should be made. And so there is an opt-out capability, obviously, but what it does, I think it fires up the conversation between the patient and the provider, and then gives them the asset to be able to quickly make that referral and have it happen and understand what the assets are out there.
And this is Jill. I can add too that there is a verbal consent process that you note in the application. So as our team is having a conversation with the patient about the resources that are available in the community and would they like to be referred to those organizations, we ask that and obtain their consent.
Yes, and I have an example right here that I mentioned. Thank you, Jill. Thank you, Hans.
Great. So I think that Hans, you started to address this a little bit in terms of how you choose the product or how you chose the product you were going to be using. And so a question came in about if there are clinics that use different social needs screening that are part of this network. And are other screeners able to be put in there, such as what you would use in an accountable health community? And then a follow-up question that is related is about whether there's a statewide discussion, you know, how sort of broad was the conversation on an assessment to be put in there that involved the providers of care at the primary care level?
Yeah, and so the assessment is not locked to Prepare. We launched it with Prepare because of our partnership with the Idaho Primary Care Association, conversations we had with CMS, and conversations we had with the National Association of Community Health Centers. Everybody kind of wanted to see what a statewide Prepare tool could accomplish, and quite frankly, you know, we were very close with IPCA and our FQHCs and wanted to support them as much as we could, and that was their, you know, their chosen assessment. That said, AMPRIT is extremely flexible. We can add any assessment that is available on the market today. We can also make custom assessments and put them up so that either one individual practice can use it because that's the assessment they like, but it can also be available to others. So it's not restrictive whatsoever. It's just how we first launched the program. And Jill, I don't know if you want to follow up with that.
Right, and I think they're all very, very similar. I like the Prepare. I think it's very similar to the Health Leads one that we've adapted into our Meditech. And I think there's a question about kind of the top social services needs is housing and transportation and food has been ours in our North Idaho region.
And that reigns
Yeah,
true for the entire state.
It does ring true, yeah. And, you know, we had an interesting discussion with, I think it was with Boise State University, who had reached out and done some conversations with different types of providers. And there was a conversation that came up around social status, if you will, and the questions in Prepare around other questions and other assessments that may be more appropriate at higher economic levels. And so we took a look at that as well. And, you know, it sort of rung true in some places. So that's why another reason why we selected this is because it was so flexible that we could put up anything we wanted to. But an interesting conversation it was, in that how you address that issue with different social economic statuses of populations.
Great, thank you. So there's a specific question about how much work this really creates for the community-based organizations to close the loop. Are you observing that they have a sort of double data entry issue around duplicating internal documentation for their clients, patients?
From my perspective, and I'll let others talk about it too, but from my perspective, it's a pretty light lift for the community-based organizations. As far as actually closing that loop, it's essentially clicking a button saying that they have completed it or not. Community-based organizations can utilize the Aunt Bertha platform as robustly as they want. There are some that may use it to its full capacity, and there are some that may just not use it at all. And our intention, especially with our group that we're creating that's surrounding the community-based organization engagement, is that we're essentially reaching out to those who have not been necessarily claimed, is the term that Aunt Bertha uses, and work with them to help them understand the value of using Aunt Bertha because of the ability to share data across multiple health systems, the ability to work to look at population analytics from the assessments and from the data derived from Aunt Bertha. So in my mind, it's a fairly light lift, but community-based organizations can participate at their own pace and discretion.
Yeah, and I'll add that the reason, being an HIE, we can integrate some of this data into their EMR systems, and quite frankly, also our EMPI can fill out the patient demographics, so we can lighten the workload in a number of ways. And the idea here, as we mature with our CBOs and frankly our practices and get more and more extensive bidirectional interfaces, we can help to avoid a lot of the dual paperwork. And as they work at Gravity to actually make the data that comes out of these new systems more interoperable by applying codes to them so they're machine readable, and working on that nomenclature so that we can trade this data more freely. And that's a really important project, Gravity. If some of you haven't been watching it, I would recommend that it come onto your radar screen. Laura's been working very closely with them, and they are coming up with standards to be able to exchange this data, which we think will break the dam open.
Yeah. That being said, I believe transportation was just submitted and voted on for the code set, and homelessness is up next.
Wow.
Yeah, very, very exciting, very exciting. And I see this last question here from Dr. Miller. Closing the referral loop, does the documentation of done automatically get documented and linked to the referral in the EHR? In the Aunt Bertha instance, it does, but that's speaking solely on that cloud-based platform. Now, Jill might be able to speak with the integration into the EHR because her Aunt Bertha instance is directly integrated into the EHR rather than through the HIE. Does that happen on in your instance, Jill?
Yeah, we're not connected yet, but with our EHR with it, but there's a couple different notification mechanisms that you are aware of the completion of the referral. You would get an email, as well as there's a dashboard that you can track all of your referrals. But eventually, when we move to Epic and we do the interface with Aunt Bertha, we would be able to include that information in the EMR so that we're all aware what referrals were completed and what ones are still left out there that we can do additional follow-up.
Thank you. There was one other question that was also around the topic of the product specifically. Oh, actually, there's yet another question. So Dr. Rauner in Nebraska was concerned specifically Prepare seems designed primarily for an FQHC population rather than a more general population. And he referred to a form shared in the CPC Plus program, the UC Health, Social Determinants of Health form that may have a better general population. So that's just as another option for people who are looking at this as a series of things they may consider implementing. And one more question that just came in. Are you finding that the CBOs have interest and capacity to respond to an increased referral volume?
And I can talk about that. I think our community partners have been really excited about the tool, not only for them to receive referrals in a more streamlined manner, and being able to track and get reporting on, you know, how many referrals are they getting, and even access to their posting on the page. I do think that really the small organizations really have to, they struggle a little bit in having a dedicated person that will receive those referrals and respond to. You can assign different administrators that can be involved in getting those referrals and responding to them. But for the majority, I think the community organizations are very excited about the tool. They use it as well for their population. And some have said they'd rather spend their money being on this site and optimizing the site than they would even with the white pages. Because if it's out on the white pages, that information, if they want to change their hours or they want to put an intake form or they want to use it in a more robust way, it's a much more robust functional site than a static posting on a directory or a printed version of some kind of directory.
Thank you, Jill. We have just a few moments left, and there is one more question that, thank you, Hans, for pointing that out, from our intern, Sanika Kumar. She's curious what the vendor landscape looked like for products like Aunt Bertha when you were beginning this process, and were there a lot to consider? Would you really describe, I mean, no one's going to hold you to this, but is this really the gold standard from your perspective? Sounds like it's a lot of flexibility, certainly. It's been working well for you.
Well, I'll let Laura address some of this, but from my perspective, we did a very wide search and talked to an awful lot of vendors. And as I've said before, there are a lot of good, there are several good systems out there. For our needs specifically, we felt that Aunt Bertha was the most mature in our particular region with the assets that they had cataloged and the capabilities that we needed in the extremely tight time frame that we needed to stand this up. This was done under a Support Act grant. Well, actually, it was supposed to be, but it didn't. It wasn't in the end. But we only had 4 months to establish this and really, truly all of the rest of our stack from A to B to get it standing. So it was, for us, it was the best choice. And Laura, I don't know if you want to add to that.
Yeah, absolutely. Just to piggyback on that, we spent a considerable amount of time narrowing down the candidates, and there were a lot of worthy candidates and a lot that we had multiple demos of. And ultimately, it was just understanding that the landscape within the state of Idaho really supported the integration of Aunt Bertha within our staff. And I can honestly say that I felt like every platform that I reviewed and viewed had amazing attributes, but this one was the right fit for us. And I would certainly, when you're doing your due diligence, really think about the landscape in which you're putting this out there. Think about who is already using a social needs referral platform. and really start thinking about how you want to expand in the future. And as Hans alluded to many times, our relationship with Aunt Bertha is really solid. They are great partners. They are willing to be extremely flexible with us. They have been talking to us about this referral platform that we are talking about with the Dental Association and IPCA. So it's a big deal that they are willing to be such flexible partners with us. So that was one of our reasons too. So the landscape is huge, but that's how we knew
it is. There is one thing I would add to that. It was kind of interesting is because there are some outliers that do a number of different things, but include social determinants of health capabilities. And while we were looking for quite possibly more rounded platforms, the funny thing is that when we got into those conversations, they said, well, we'd have to go to Aunt Bertha for that, but we can integrate with them. And we got that a number of times, which sort of drove us in that a little bit more in the direction of Aunt Bertha, because some vendors said, well, we can integrate with Aunt Bertha for that. We can integrate with Aunt Bertha for that. So that was kind of an interesting thing that kind of popped up a little bit here and there.
Mm-hmm.
Okay, well, thank you. I have 1 o'clock now in Eastern time. There's one last question that maybe can be answered quickly. Just how many screenings and referrals have been made, sort of on an order of magnitude so far in this?
I don't have exact numbers at this point. We have a few pilot sites that are working through this on our side, and then I'll let Jill talk from Kootenai's perspective as well.
As far as screenings, we screen all of our admissions with a kind of a social determinant psychosocial assessment. So all of our patients get that. And as far as referrals, we haven't done the formal closed loop referral tracking yet. We're still working with our community partners, and we're piloting with the mental health going forward. But our staff does use it to identify resources that we then can give to the patient and connect them to that resource.
Great.
Yeah, Lisa, we could send you some numbers on that if people are interested. Aunt Bertha would have that. We could dig that up if you'd like.
Okay, thank you very much. So I want to thank our speakers for a really fabulous presentation and a very exciting program to be hearing about. I suspect you'll be getting some questions and comments from multiple people who are on this webinar right now. So thank you once again for your great work and your generosity in sharing with us. We are going to be taking a 10-minute break. I'll be back here and getting started at 1:10. Really looking forward to our next couple of presentations. Once again, thanks to the Idaho team, and great to have you with us.
Thank you so much. Thank you.
Yeah, thanks for having us, Lisa. It's good to be here.
Absolutely. Welcome back. This is Lisa Watkins with the Millbank Memorial Fund. We're going to be getting started in just a moment. We're just letting people come back to their chairs. Very excited about this next two presentations, as certainly we enjoyed the first one today. Okay, well, I think we can get started. So it is my great pleasure to introduce our next panel of speakers and the next topic. We're going to be hearing about social determinants of health screening, outreach, and delivery on the ground in Ohio. And we have with us two representatives of very important partners in this effort. And I'm going to just introduce them to the crowd right now. So we have Ivory Patterson, who works at the Health Collaborative. She is the manager of partnerships and quality improvement for the Accountable Health Communities Project. She drives performance and process improvement in that effort. And she utilizes her science, technology, and engineering and math background for data-driven, evidence-based solutions. She's also responsible for managing partner relationships, develops resources, model flexibilities, and assists with customized workflows to ensure success of all of the partners engaged in this. And she has a strong background in healthcare equity and brings that perspective to the internal team projects. Also, we will be hearing from find it. Chris, here he is, from Christopher Valenti, who is the team lead of the Integrated Care Management Team at CareSource, which is the by far largest provider of Medicaid managed care resources in their part of Ohio. He has a bachelor BSN in 2004 in nursing, and has a specialty since becoming an RN in neuro, ICU, informatics, compliance, and care management. He is relatively new to his role with CareSource, but has very graciously, gamely agreed to be part of this. So with that, Ivory, I'm going to stop sharing my screen and have you share, and we'll see how that works.
Okay. Give me just one moment. Good afternoon, everyone. And all right.
As a quick reminder, if you are, sitting at your desk, just make sure that you're muted, because there can be intermittent noise just from life in general while you're on a Zoom call. Okay, great. We look like we got your screen up here. Thank you, Ivory.
Awesome. So good afternoon again. My name is Ivory Patterson. First, I work for the Health Collaborative. And so we are a nonprofit organization based in Cincinnati, Ohio. We're health information exchange for our region, and we specialize in data-driven solutions to improve healthcare for those in our service area. So GenH Connect is one of our initiatives. It is actually a Accountable Health Communities project that is sponsored by the Centers for Medicare and Medicaid Services. So just wanted to say that first, and I'll go ahead and get started with my presentation. So we know that the missing link in care is really due to social determinants of health. Majority of health outcomes are attributed to those factors. And I will skip over the case for integrating social determinants, because that is why we are all here today. And so I'll just get into more of the details of our model here. So again, this is a 5-year demonstration project sponsored by CMS. Our overall goal was to complete 56,000 screenings and 2,187 navigations during project year 2 of this model. Due to the pandemic, we are a little bit, that has thrown our operations off just a little bit. We are actually in project year 4 now, but just some other challenges that we faced in this model. We are not quite at that 56,000, but we are certainly pressing toward that goal. So for this model, again, we're a bridge organization. So we are the center spoke on this wheel. And so we have partnered with a number of clinical delivery sites as well as community partners for this model. And so we partner with health systems here locally, which include Cincinnati Children's Hospital, the Christ Hospital, Tri-Health, and the University of Cincinnati and their medical center. We also partner with community health centers such as Centerpoint Health, the Cincinnati Health Department, Crossroads, Talbot House, and then the Warren County Health Department here as well. In regard to our trusted community partners, you'll see, as Lisa mentioned, we certainly partner with CareSource, and you'll hear from my colleague, Chris, and he'll give you a bit more information about the navigation of our beneficiaries. But we also partner with the Council on Aging here in Ohio, as well as the Community Action Agency, Healthcare Access Now, Molina Healthcare, which is another Medicaid managed care plan, as well as United Way, and then the Ohio Department of Medicaid. So what is our model? What do we do? Very similar to the group from Idaho that went just before I did. So there's screening. We first screen for, we call them health-related social needs. It's a bit more of a narrow focus than the broader social determinants of health. And so those health-related social needs that we screen for are food insecurity, housing, utility assistance, transportation, and interpersonal violence. And so screening is that first step. The second step is for those who are identified as high risk, and I'll get into what high risk means in just a moment. But those who identify as high risk are then referred on to our navigation services. And so our navigation services, that's where Chris and his team would come in to provide assistance to that high risk population to connect them with community services. And the other unique thing about our model is that we're an alignment track organization. And so what we do with this model is we're on the alignment track, excuse me. So we're aligning with community health initiatives. So just who we are as an organization, we are uniquely positioned with existing partnerships. We partner with the Greater Cincinnati Food Policy Council, just one example, who are really doing a lot of great work in the food equity space. And so that was an alignment opportunity there. We need to identify resources and assess the availability and accessibility of these resources so that we can connect our beneficiaries. So that's a wonderful alignment opportunity there. The Council on Aging, again, another one of our partners, they have received a really great opportunity. There's a grant for them to provide non-emergency medical transportation. And so we know transportation or lack of transportation is a barrier to accessing some of the care that our beneficiaries may need. So that's what we do in regard to alignment activities. Now, how does this all work? So the conduit through which we are able to do this work, similar again to a group from Idaho who utilizes the Bertha platform, we utilize the Healthify system for this model. Very similar, so the screening tool is embedded within that platform, and screeners and navigators are able to use that platform to identify those health-related social needs. And then they're also able to use that platform to navigate those beneficiaries to the resources that they need. So the first step, as you can see here in our workflow, this is just kind of how we stratify between the different risk levels. And so for low risk, it's really if they've been, if they have not been to the ED 2 or more times, and or do not have at least one health-related social need. So in that screening tool, again, that's where they're going to identify those needs. And so really the difference between low risk and high risk is that ED visit. And that's because as part of the Accountable Health Communities model, it's really just one big test of change. And what CMS is testing is, can we reduce ED utilization or unnecessary utilization and lower healthcare costs by addressing these health-related social needs. And so that's why we stratify between high risk and low risk based on ED visits. So, but all beneficiaries, regardless of their risk level, they are going to receive what's called a tailored community referral summary. This community referral summary is, again, generated within the Healthify platform. And what that is it's a list of resources with hours of operation. And so one of our most popular food sources here is what's called the Freestar Food Bank. And so, for example, the Freestar Food Bank and their service offerings, eligibility will all be included in that document that the patient is provided with. Now, if they are high risk, that document will also be included in the referral and sent over to our navigation partners for one-on-one really coaching. There's a personal interview to better understand their identified needs, and then an action plan. How do we plan to resolve these needs? What resources are we going to connect them to? And really exciting, very similar again to our other group who has CBOs participating within that Bertha platform. We also have CBOs that are now live within the Healthify platform. And so it's really great that they can now receive these referrals from our navigation partners, and really does enhance that closed loop referral process. So the screening tool, just to give you a little bit of background on that and how that was developed. We do not use the Prepare tool. We are required to use Because this is a CMS demonstration project, we are required to use the tool that they have helped to develop. And so that's all stood up within the Healthify platform. So that is pretty much the end of my presentation. And I can pause for any questions that you all may have.
Thank you so much, Ivory. So obviously the chat option is open if people would prefer to send their questions in that way, or any questions people would like to ask right now while we're this moment. There are going to be a lot of questions, Ivory. Don't think you can relax too.
Well, and if you want, I can go ahead and give just a little addition to what Ivory was talking about.
Absolutely, yeah, Chris.
And then we can maybe answer any questions at the end that. And what Ivory said is absolutely correct. And as CareSource, we are the largest Medicaid MCO in Ohio. We have the largest population of those members. When we get those referrals, our community health worker reaches out to that member and does their best to resolve those needs, identify even more needs if they have them, and work within the Healthify system to find resources that are available for them. Follow up with the member, the best we can. Obviously, you guys know that this is a very difficult population to contact and stay engaged with. Once we do that and we identify more needs, we try to engage them into our case management program. And with that, we don't necessarily have more resources that Healthify has, but we're able to dig a little deeper into some of the other resources may be available for that member. And we can also dig into those medical needs if that is one of their barriers to getting the resources that they need. The bottom line is, we want to meet with that member. We want to find out what their needs are, and we want to try to resolve them and have them in a position where they really don't need us.
Mm-hmm.
And that's really it as far as the relationship with the Gen H Connect and doing the closed loop. And again, the hard part is just being successful in maintaining contact with those members.
Yeah, absolutely. I do see a few questions in the chat. So from Dr. Miller, it looks like she's asking if I can walk us through the closed loop process once the referral has been made. So piggybacking off of what Chris has shared, basically we ensure that closed loop referral, that's really on the navigation end. And so through Healthify, you can track needs resolved, was the need met? And so we track that all within that system. You can add notes about what happened with that contact with that beneficiary. Was this contact successful? Was it unsuccessful? And why was it unsuccessful? We want to know all of that information. And so that's how we track it through that platform. And so really it's up to the navigator to follow through with this beneficiary. Were they connected? If they were referred to the CBO, I'm going to follow up with you. There's we're required to follow up within 2 weeks before closing anything out. And so did they get connected to the resources that they need? Yes or no? So that's the navigator's job, and that's their workflow.
And I can answer the next question, Ivory. And the question is, do you do home visits? And we absolutely do. Right now we're not because of COVID, but once we get over the constraints of COVID, we'll be back to doing home visits.
Mm-hmm. Yep. Home visits are part of, there's a process, right, for our contacts. They have to make 3 attempts to contact the beneficiary. And so usually the first is a phone call, but usually that second one is a home visit if we're not able to reach them. And so again, we just don't feel it's safe at this time to send our navigators out to do that. But as Chris has stated, as soon as it's safe to do so, they'll resume that process. And then Dr. Holly also asked if this all gets documented in the EHR. We are working on that. We're working on integration right now with a couple of our health systems. And so there'll be more information to come on that down the line. Can I tell you about the Bridge organization and how is the Healthify platform similar or different from Bertha? That's a great question. A Bridge organization, basically within the Accountable Health Communities model, is the organization, basically the organization that is responsible for facilitating these activities. And so we just happen to be a nonprofit organization, but in other state models, some Bridge organizations are actually health systems. And so I think it really depends on the entity that was interested in doing this work and who has the capacity to facilitate this. Because of our position in the community, we just had the ability to bring all of these stakeholders together because we're already partnered with them. They were already part of our member board. And how is the Healthify platform similar or different from Bertha? I unfortunately can't speak to that too much because I'm not as familiar with Bertha, but what I can tell you is that very similar to Bertha in the process that I just saw previously, it's very, very similar. The screening tool is embedded within Healthify, and then the navigators also have the ability to kind of follow the beneficiary through that process in Healthify. But then the Healthify platform has over 600, I believe, community resources. And so our navigators, they use Healthify to identify where those resources are, and they can even do it within the proximity of that beneficiary's residence.
Yeah, and I'll just add to that. We use Aunt Bertha as well, but specifically for the Gen H Connect project, we use Healthify because of the closed loop aspect of that. Whereas Aunt Bertha, we don't necessarily use it that way, but we definitely use Aunt Bertha for many of our resources.
Yeah. Looks like Deborah has a question. Chris needs to do his presentation, but I'm gonna answer these next couple of questions and I'm gonna turn it over to you, Chris, for your presentation. So is this integrated?
That's really all I needed to add on was just piggybacking off yours. So we're all good.
Oh, okay, good to go.
Yep.
Is this integrated into the state HIE? Yes, so we are, as a health collaborative, we are the health information exchange. We do that through our work with HealthBridge. I'm not this person who can speak to the technical aspects of that, but what I can say is we did use this capability we're able to kind of auto-populate the patients in the Healthify platform. So even if they have not gone into one of our health systems to be screened, because their information is within their EHR, we were able to automatically populate some of this info to make it a little bit easier on our screeners and navigators. So yes, it is associated with the HIE. And so in terms of care coordination, yes, this whole platform and this whole model, this is really to enhance that care coordination. And so that's why we're trying to do and stand up integration so that we can enhance that process. And so we do want to make sure that we're reducing the duplication of those services. And we're working very hard to do that, and integration is going to help us out with that. Does a CBO enter that the patient's needs were addressed in Healthify? I'm going to say yes and no. CBOs who are live in the Healthify platform, yes. So if our navigator were to send this referral to a CBO that's currently participating, then yes, they should be hearing back from the CBO and letting us know that we're not really letting us know, but like documenting within that Healthify platform that yes, their needs are addressed. And once integration is stood up, yes, then the clinical care teams will be able to see that as well. For those CBOs that we refer to that are not currently live in Healthify, we still need to track those referrals, but it's really up to the navigator to kind of call the CBO and follow up the beneficiary to check in and make sure that those needs were resolved.
Yep, you nailed it, Ivory. That's absolutely correct.
Thank you, Chris. Any additional questions for Chris or myself?
So this is Lisa. I have actually a sort of higher level question. And in terms of, obviously you're dealing with many patients and their families. And I was wondering what, if you've observed anything in terms of resistance to having this kind of an intervention, or if people are, is there some hesitancy about privacy issues or anything like that, and how you've addressed that?
Yeah, so I don't know that there's been any hesitation regarding privacy. I think that they want us to stop calling them sometimes. And I say that because, with the shift due to the current pandemic, we've shifted a lot to remote screening. And so sometimes when you're getting that follow-up phone call from your physician and you're getting that appointment reminder, and then we're calling you to do the screening, sometimes it can be a bit much. And so we have seen that resistance that they don't want to answer any more questions, but not really in regards to privacy. I will say that something that we are working through currently is we are finding that the Latinx population is underrepresented in our data. And so we do feel that that might be due to some fear of reporting, just due to the current landscape, certainly understandable. And so we're working on making sure that we're asking these questions. Well, one, we have translated all of our materials into Spanish, and they're available in other languages as requested. So we've done that. We're also shoring up our race, ethnicity, and language data collection efforts. And so there'll be more to come on that. But we want to make sure that our screeners and navigators are equipped to ask these questions in a culturally appropriate and respectful way.
Thank you, Ivory.
Mm-hmm.
Dr. Shank, I know that you're on the line and work closely with the team that's doing this terrific presentation today. And I just wanted to make sure that you had any comments or observations that you wanted to make sure the group heard.
Actually, thanks, Lisa, and Ivory and Chris, both a great job. I'm actually learning a lot as I listen to you guys. It's great. I didn't get this kind of an update before, so it's good to get the feedback. I do know, and I would like Ivory to speak to it a little bit more. And I see a couple more questions in the chat that kind of are getting at this. I think maybe when we kind of had you guys focus on the relationship between what we're doing with, say, a payer, CareSource, maybe we got a little too focused too quickly, because I know that there are a lot of other organizations and community organizations, Ivory, that we're working with in this project. I wonder if you could speak a little bit more to that and kind of some of the interactions there.
Sure. So again, we partner with some of our health systems. It's a pretty diverse group that we have here for GenH Connect in terms of the type of organization. And so our first partnerships are certainly with health systems and community health centers as well. And I think that the operations look different at both of those types of organizations. But what I will say in terms of that engagement, everyone who has participated seems very committed to addressing health-related social needs. And so I think that really is across the board, from screening sites to navigation sites as well. We're all here for the same goal. And so that's always nice to see that we don't lose the enthusiasm and commitment, not really to this model. It's not really about us. It's not really about CMS. no disrespect to CMS, but it's really about connecting the beneficiaries to the services that they need. So it's great that we're all aligned there. But some of the other partnerships that we're asking about in the chat. So again, like the Council on Aging, we have a partnership with LISC, and Dr. Shonk, you might have to help me out with that acronym, but they provide resources for housing assistance to low-income families. And so that's another alignment opportunity that we do have. Our organization, we're kind of starting up some advocacy efforts as well. At the beginning of the pandemic, there was a cut to, it was a lot of money. It's about in the millions to Medicaid services and to some other social services as well. And so for us, it's really unfortunate that social services is kind of the first to go because we really do need those resources. So engaging in advocacy to make sure that those resources are available and accessible in our community.
Yeah.
Does that answer the question, Dr. Shonk?
Sure. Yeah. I think you could talk a little bit about the question in the chat about food policy council, and I know that food was recognized as one of the biggest needs, and how we're handling that.
Sure. So the work with the Food Policy Council, it involves a number of stakeholders as well. So Cincinnati Children's, the Free Star Food Bank, and what we really are trying to do first is identify where the gaps are. So we're using some of our data through the AHC model to really map out where the food deserts are, where those gaps are, comparing our data with the research that the Food Policy Council is able to gather, and really trying to align on this community strategy to address these food deserts. What do we need to do collectively to ensure that these resources are available? The other really great thing that we've been able to do is overlay our transportation data with our food data, because a lot of the times, if I don't have the transportation to get to the grocery store, I know, especially in the pandemic, there was a lot of just doing grocery pickup, but I can't go pick the groceries up if I don't have, a vehicle. And so just aligning in terms of, where the transportation deserts. So we've been able to do, we've had a lot of great momentum. I think we're still in kind of the research phase right now, but more to come on some more actionable steps.
Yeah, so a couple more questions. One is a specific question around how you obtain consent from patients that have been identified to make the referrals, and then obviously the next step of sharing data for coordinating care.
Sure. So that consent is embedded within the screening tool. So before we start asking those questions, screeners are required to obtain that consent. So we have a standard consent policy. If they do not consent, then we count that as an opt-out. They're opting out of screening services. So that's the first thing. They can also, there's also consent for navigation services. So before that screener sends this referral, we do ask the question of, are you okay with having someone call you and follow up with you based on your identified needs? So we obtain consent for both screening and navigation. Consent for sharing the data, I think it's kind of all rolled into that consent language that we include in the surveys.
Great. And so then sort of where the magic happens in terms of where the screenings are done. The question was what type of healthcare settings and the roles of the individuals who are working in those settings are doing this screening. So where that actually happens. Yeah. So a specific question around providers versus social workers or potentially community health workers, and sort of how those various team members work together.
Sure. So so I know saying that it occurs in health systems is a bit broad, right? So we typically, for this model, we're trying to screen in 4 different clinical areas. So that is within the ED, there's some screening that takes place in labor and delivery, behavioral health, and then primary care as well. We want to make sure that we cover a vast majority of clinical sites. We're also required through some of the stipulations in our agreement with CMS to make sure that we cover these areas. And so within our health systems, we certainly make sure that screening takes place in that regard. And then in terms of our community health centers or FQHCs, that takes place really at the point of care. That's more so our primary care. Our primary care offices, not really a lot of specialty clinics at this time, but we are thinking about some different expansions. Maybe we can expand to dental, for example. And so more to come in that regard, but those are the settings. In terms of the individuals doing the screenings, they're typically not physicians, just to be mindful of their time. What we have found is the most beneficial is the utilization of community health workers to conduct the screening, as well as navigation. As Chris mentioned, his team, they have a community health worker dedicated to navigating for this model, but that's the same on the, it's pretty much the same on the screening side as well. In terms of health systems, we really do utilize a majority of community health workers. Now, there are some times where that's maybe like a front desk person, just really depends on the capacity and the staffing of that clinical location.
Right, so you have a wide variation around the types of centers that you're using, obviously.
Yes.
Yeah,
Mhm.
and Lisa, along that line, one thing that Ivory may not have line of sight into, but what we've been able to do since we have one of the largest CPC plus efforts going on, we are really looking for ways to link this to the capacity of the primary care practice with their additional care management resources that project gives them. How can they make best use of this data? So that's also a work in progress that we are exploring.
Awesome.
Great. Looks like there was one more question that came in from Eric Muther from the CPC Plus project in Philadelphia. And so asking a specific question around consent or engagement, working with various minority or ethnic groups.
Mm-hmm.
I suppose that could be a language issue as well. I mean, there are lots of ways.
Yes, yes. So, yes, again, the Latinx population is underrepresented in this model. And so there are efforts underway to ensure that all of our screeners and navigators are engaging in a culturally appropriate and respectful way. I actually happen to be trained as a subject matter expert for race, ethnicity, and language data collection. And so that's something that I am contributing to this model, and we're in the process of developing tools and resources and trainings just to make sure that all of our screeners and navigators are able to engage in a culturally competent way. We've also made sure that, our community health workers, and I'm a little bit, I forgot to mention that we do use AmeriCorps volunteers at sites who need it. And so we're making sure that the screeners and navigators are representative of the populations that they would be screening for, making sure to try to hire for those who are bilingual, who might speak Spanish. So that's a bit more culturally competent there. And so efforts are underway to really try to help us gain more representation from the Latinx community.
Great, thank you. So I can see Ivory reading the same question I am. I'll just, I'll read it out loud. So first of all, just really, it's really a pleasure to hear about your expertise in race and ethnicity data collection, something that is on everyone's mind appropriately currently. But Sana had a question specifically around evaluation plans. And looking at the impacts. I mean, I would put that more generally, but also the specific question that she had was around looking at disparities.
Sure. So what we are doing currently in our data collection, so we, how this model is structured, we have an advisory council. And within that advisory council, we have subcommittees. So we have a quality improvement subcommittee, we have a health IT subcommittee, and then we also have a health equity subcommittee. And within that health equity subcommittee, on a monthly basis, we come together and we analyze our data. And a lot of that data we're stratifying it by race and ethnicity. And so we are also required by this grant to identify target subpopulations who are at a greater disadvantage. And so what we've identified for here in our region, the African American community in Hamilton County, as well as the Latinx community in Butler County, are in need of equitable access to resources. And so we look at that data and we look at, have we improved? Do we have greater needs resolved for these populations? Are they getting connected to the resources that they need? If not, why not? And then what can we do about it? So we do evaluate this on a pretty routine basis.
Yeah, I was just gonna add that the one kind of unexpected benefit of this program, and again, it's related to how we've been able to integrate it with a lot of the other programs that we have going on, and I'd like Chris to kind of comment on this, because I know that the health plans are especially the MCOs, are very sensitive to the gaps in care measurement. And so what we have been able to do is try to link this as we make contact with these folks through this navigation, and especially with our Council on Aging, but also in the Medicaid space, is how do we take this opportunity to interface with these folks to make sure that they're getting the necessary screenings, the necessary activities within and to actually fill the gaps in care that we oftentimes see in this population. And I know, Chris, have you seen any impact of that? And is it something that you're watching?
Yeah, so we absolutely, one of our, just to generally meet NCQA standards and our state mandates, is we do have to look at HEDIS measures and do our best to try to meet those, get the members hooked up with the right physicians, and get those tests done, and then monitor them, based on what the results are. It is, as you guys can imagine, that is a real struggle. People, you set up appointments with them and for them, and they don't make it, or they're PCP shopping and those types of, so it is a real struggle that I'm sure we all deal with. But yeah, we are continuously monitoring that, and hoping that the impact will be positive for our members.
Yeah, it has been difficult with the pandemic because people are not going in for their tests for other reasons. But it is, and we actually have some internal efforts to calculate this, but the pandemic has kind of waylaid the baseline, and so it's difficult to know how much progress we're making in an aggregate way. But it is something that I think, just for others on the call, if you haven't looked at the gaps in care approach to this, I think it's a great opportunity in these programs to actually connect that.
And that's a good point. One of the other things that on a state level is there has been a shift from our normal gaps in care of HEDIS to, what kind of COVID response do we have, right? So that's absolutely been a change and a direct result of COVID.
Yeah.
Mm-hmm. Okay, any other questions that have not risen to the top yet? Well, I want to take this opportunity to thank both Ivory and Chris and Dr. Shank for chiming in. Just really terrific presentation, a very exciting program. As I mentioned, we're recording these. So if there are colleagues that you have who would like to listen to this conversation, didn't have a chance to join us today, that will be available on the Millbank website. What I'd like to do is break for another approximately 10 minutes. We have a wonderful third presentation from our colleagues at MyHealth Access in Oklahoma. So at this point, I see the time is just 10 of 2, excuse me, Eastern. So we'll come back in about 10 or 15 minutes, give you a little bit longer for your bio break, and we'll get started with our third presentation. Once again, Ivory and Chris, thank you so much for a wonderful presentation and for the incredible work that you're doing. Welcome back, everyone. This is Lisa Watkins with the Milbank Memorial Fund. We're going to get started with our final presentation of today's seminar in just a few moments. I would like to take this opportunity once again to thank all of our speakers and participants for being part of this event. And I'm really just delighted at the quality of the presentations, obviously, but also the quality of the discussion and questions. So thank you all for being part of this. As a quick reminder, many of you are CPC Plus and Primary Care First payer organizations that you work for, and all of you received a note from me yesterday asking for you to please fill out our payer COVID payer response survey. Many of you remember that we fielded a survey asking how payers were responding in support of primary care practices in the early days of the pandemic. This is the second version of this survey. I had this very aspirational goal of getting everything finished by the end of 2020. That didn't exactly happen, but that's fine. The due date has been sent into the next week. So please take the 15 or 20 minutes or so we'll require to fill out the survey. You can either do it by SurveyMonkey, there's a direct link in that email, or you also should have gotten a Word document if you prefer to send the results to us by email. With this survey, just as an aside, was created in collaboration with our colleagues at Mathematica. So I'm very, very pleased with the quality of the questions, and they will be helping us with our analysis as well. I think we are just about at the 2:05 moment, so I'm going to take this opportunity to introduce our colleagues from MyHealth Access, and they're going to be speaking about the Oklahoma Route 66 Consortium, about their mobile social needs screening tool. So I'm going to just introduce our colleagues. Jennifer Ferries is joined MyHealth Access a couple of years ago in 2018, and she is the implementation consultant for the Accountable Health Communities Cooperative Agreement with the Centers for Medicare and Medicaid Services. She is now the program manager of the Accountable Health Community Project, and sees the overall day-to-day operations of that. She's now also the director of the project management office at MyHealth Access Network, where she leads a team of project managers and program staff. And she has been involved with this particular tool's development and pilot, and now fuller implementation since the very beginning. And I'd also like to, with pleasure, introduce my colleague David Kendrick, who's the founder and CEO of Oklahoma's Health Information Exchange, which is MyHealth Access Network. Serves more than 3 million patients statewide in Oklahoma. He's the principal investigator for the Route 55 Coalition, which they'll be describing in some detail, which is Oklahoma's Accountable Health Community Social Needs Intervention Program. MyHealth provides region-wide quality measurement for the Comprehensive Primary Care Plus program, and previously did for Comprehensive Primary Care Classic, as well as for the accountable care organizations and value-based payment models in Oklahoma. There we're going to turn it over to Dr. Kendrick and Jennifer to work on this. We'll hear about this terrific project. I don't know if Jennifer has made it back on. We'll see.
Yep,
but,
I'm here.
Oh, yay. Welcome. So I'm going to stop sharing, and that will allow you to share your screen.
Okay, just confirming you can see just my slides.
We can. Thank you, Jennifer.
Okay. Perfect. Dr. Kendrick's going to kick us off here.
All right. Well, thank you, Lisa, very much for the introduction. It's always amazing to spend time with this group. This is where we get our batteries recharged after work in the communities. It gets rough, especially during this pandemic. So thanks again, Lisa, to Milbank and the rest for making this forum available. All right. So MyHealth, as described, is the nonprofit health information exchange in Oklahoma, founded in 2000. 9 and 10. We were Beacon Community. We now connect over 80% of the healthcare data in Oklahoma, and move this data forward. And if you're noticing a trend here, which I found fascinating, all three of the organizations presenting today are the health information exchanges for their regions. And I think that should not go unnoticed by everyone here, because these organizations have a role to play that's sort of in the between space, right? That is a middle layer in it between healthcare delivery and payment, between government and private sector, between, you name it, the health information exchanges, especially, the nonprofit organizations that have filled a gap in an important place in our healthcare delivery system. That's not just about data; it's about trust and relationships, and and a lot of other things that we and the rest of our colleagues facilitate implementation of federal policies and get information back from the grassroots to comment on those. there are a lot of roles we play. So in any case, our job really is to serve as a trusted entity in the middle and to do what the community needs us to do. And so when this funding opportunity was announced in 2016, MyHealth really stayed out of the conversation too much. We were aware of it and we reviewed it, of course, and the community, as communities do, lots of organizations began meeting and planning their proposals, and it became clear to folks that no one organization could do it on their own, and no two could do it, and no five could do it. And by the time they reviewed the requirements of the bridging organizations, which I really thank the folks at the Health Collaborative for doing a nice job of describing, so we don't have to spend too much time on it here, it became clear that really the place to park this project was at MyHealth. And that was a really good sort of independent indicator that MyHealth, that we had positioned our organization in the right level of the community. And so they approached us. We filed the application as the bridging organization, and we were one of the original 32 selected for this. Next slide. So go ahead. This is you, Jennifer.
So as our cohorts shared before us, we are a part of the CMS Accountable Health Communities model. We have been so excited to have done this work now for, can't believe it's been 4 years, but we've been doing it for 4 years. We're getting ready to enter the 5th year of this project. I wanted to point out just specifically, I know there was the group, the very first group talked about the Prepare instrument, and Health Collaborative mentioned, with the CMS model, we are required to use the standardized screening instrument that CMS developed. So we are specifically screening for, and just wanted to point out, 5 core health-related social needs. So those are housing, food, transportation, utility, and domestic violence or safety. So those are really where we're sort of focusing our efforts and really looking at, if we help to address these social health-related social needs, will it drive down unnecessary utilization and high cost spending? Can we divert those people to PCPs, and can we get them support from, we also use community health workers. So that's some of the work that we're doing. So we also serve as the bridge organization, much like our friends before us. And, our goal and part of the challenge we had in the beginning as HIE is, we are not a health system. We can't tell staff they have to screen people. So we rely heavily on really wonderful partnerships that we have here in the state of Oklahoma. And so, there were a lot of really interested health systems. And when we came to them initially, even before I was around, when Dr. Koenig did this application, they all said, yes, we want to do it. We had talked about potentially doing a social needs, just vital signs. Do you have a housing need? Do you have a food need? And then asking detailed questions from there. When we got the standardized screening instrument from CMS, we had to kind of take a step back. It's 20 questions about social needs plus demographic and qualifying questions. So we went to our community partners and they said, oh yeah, this is great, but we don't have time. How are we going to fit this in the clinical encounter to ask, 25 to 30 questions? And so we kind of had to go back to the drawing board and think about, what space do we hold as the HIE that we could make this easier for health systems. And so we're going to tell you a little bit about the methodology we developed. We are using text message screen. We meet everyone the minute that they walk in the door, they check in, and Dr. Koenig's going to walk you through the workflow. But we are screening in real time. We have minimized the burden of screening for clinics and yet made it accessible to all their patients for every clinical visit. We too are screening in ERs, in clinics, in specialty units and hospitals. So we're accessing people in lots of different places. We also then provide back a standardized resource referral to their mobile device. So we're doing all this on the front end of what clinics are doing. So, you know, we are really approaching this as we're doing the work for the clinics, and how do we make it easy for them? We are also partnering with our local health departments here, the Tulsa County Health Department and Oklahoma City County Health Department, and they are helping us provide the navigation services that you've heard about from our friends at the Health Collaborative. So the goal for us is for this to be a collaborative project. We are part of what we're spoken about alignment track. And so our goal is to align health systems, CBOs, health departments, public health, governmental agencies, all to work together to help improve health of these individuals. And again, we are also targeting these most high risk individuals. So I'm going to turn it back over to Dr. Kendrick, and he's going to tell you a little bit about the screening and what's in it, and then how do we do this mobile social needs screening. Dr. Kendrick?
Yep, thanks. So, you know, necessity is the mother of invention, and anybody who knows about the AHC model will remember that there was a full year of preparation before the program went live, and we needed every second of it, I will tell you, because, you know, as Jennifer alluded, our initial plan, which was to leverage existing built infrastructure to gather the data through our vital signs feeds that we get from virtually everywhere, that didn't work because the instrument that CMS wanted us to use, we talked about ways to simplify the instrument. We tried a number of things. I made, I think, a couple trips out to meet with the CMMI team actually running this. And it wasn't until I think May before we were to go live in August, on August 1st, that we finally struck upon a workflow that they would approve that we felt was going to be a successful approach. We, you know, as Jennifer indicated, we don't have a forcing function in any clinical location. We're not a health system with a CEO that can mandate things happen. We are there at the pleasure of the clinic that is willing to sign up. So the proposal we made was to look carefully at what we had as a unique asset as a health information exchange. And one thing we have in spades is a live flowing clinical data. And so we know within about a minute of a clinic registration or hospital registration, who is the patient, where are they registered for care and services, and who are they going to see, among other things. And so we take the data from those so-called ADT messages and use that to create, to trigger the entire workflow I'm going to walk through with you here in just a moment. Let's go ahead and go to the next slide, and I'll describe it in detail. There you go. All right, so this is a build usually, but I'll start you on the left with the person whose arm in the slide.
David, we have the build in the next slide if you want to.
Oh yeah, let's do that. Go on to that one. Thanks. All right, so the first, this is a swim lane version, so maybe it's easier to tell. You can see the four lanes there. The first is the patient's cell phone, so essentially the patient. Second one is the clinical delivery site, what's going on there. The third lane is what we're doing at MyHealth. And then the fourth lane is our partners who are providing the navigation services to these patients. So first of all, of course, the patient checks in. And then based on that ADT message that we get from our clinical sources, we turn that into a text message back to the patient's mobile phone. And, you know, overwhelmingly, the majority of phone numbers in those messages are mobile devices at this point. And the patient then receives a text message. It basically says, hey, your doctor would like you to complete this mobile screening. And they complete it on their phone while they're sitting in the waiting room. We receive those results, again, about a minute. We process those results and score them according to the rules that CMS has given us for scoring them, although I will say we tweaked a couple of them a bit based on guidance from our advisory board. And if they're negative for health-related social needs, then that's the end. But if they do have a health-related social need, then we have a database, kind of like, not unlike Aunt Bertha's, where we have the community, over 5,000 community resources across Oklahoma. And we look in there and we identify, based on the patient's home address, what are, you know, a high quality resource, the nearest resource, and, you know, send them up to 3 resources per per need that they have. And they receive that on their phone, also in the same workflow. So probably while they're still sitting in the waiting room. And then they can contact those social service agencies directly, because obviously they can just tap on the phone number and be talking to somebody, or tap on a link and send an email. And then we also, in terms of the way the AHC program works, it's focused on Medicare and Medicaid patients. And so for the Medicare and Medicaid beneficiaries, if they identify one or more emergency room visits in a previous 12 months, more than one emergency room visit in the previous 12 months, then they become a candidate for the navigation service. So we then send their information to our navigation teams in the health department, and they'll contact the patient and start connecting them with community resources, sort of like a concierge service. And then on a regular basis, we also send reports of all patients screened and those results to the clinical sites that have and it allowed us to do the screening. And so the thing that I would point out about this workflow is it only touches the clinical system in two places, right? At the initial registration, and then when we send the reports back. So it's very lightweight. It bolts onto the front end of the clinical process, and it scales very, very well, as Jennifer will tell you when she goes through the data. So, and then I would also point out about this process, turns out that it's COVID proof. It's pandemic proof, right? So when patients began to shift to telehealth visits, they still got these screenings on their mobile devices without having to have a human there in front of them to administer the screening, which we found pretty gratifying. So next slide. Go ahead, Jennifer.
Yeah, so we thought, of course, you're probably interested in what does this actually look like? Is this easy to use? Is it, we did a lot of user testing. These are actually what the screening questions look like on a mobile device. As you can see, they're pretty easy. When we piloted the CMS screening questionnaire and had someone ask them in a clinical setting, it took about 14 to 17 minutes in a clinical encounter. We find that most patients can complete this on their mobile device in 2 to 4 minutes. So even for the patient, we're talking about a significant reduction in time it takes them to identify needs and report them. As our friends noted too, we do have privacy notice and consent all built in the front end of this. We have it available in English and Spanish. We have methodologies for the clinics to share with patients how to get additional languages. I'm answering some of the questions as we're talking here too. And there was a question about the average time from a patient to check in to get a link. So the patient actually gets the screening link within minutes of checking in. I would say within 2 to 5 minutes. Now, the patient can take the screening at any time. And so the screening comes back to the resources come back to the patient within 5 minutes of them completing the screening. So that's kind of dependent on when the patient completes the screening. And I'm going to get into results here in just a minute. So this is just a sample of what the screening looks like. We wanted to show you this is the map of what Dr. Kinnick was referring to. These are where all of our resources live in Oklahoma. We started this project actually just in Tulsa and Oklahoma City, and we're granted a geographic expansion of the full state. So we now can serve patients who live anywhere in the state of Oklahoma. The two blobs of bigger blue are our major cities, and that's where a lot of patients get care. But we do have resources available for everyone who lives in any county in the state. And then this is, again, I'm sure you want to see what it looks like. This is actually what the resource looks like on a cell phone. So we specifically made this very user-friendly on a mobile device. It's all designed for someone to view on a mobile device. So if someone needs immediate help right then, we have a clickable link to our partners at 211 where they can call and get assistance. All of the phone numbers and websites, email addresses, someone can sit in the waiting room at the hospital and click that and reach out to a CBO. So this is kind of how it looks from a beneficiary. And since we've started this process, we've gotten feedback from our clinical sites that say, oh my gosh, this is great. How do I share these resources? What if someone's in my clinic and they want to ask me? So sort of an expansion of this project is that we have developed, much like what Aunt Bertha or Healthify do for our peers, we've developed our own community resource inventory. And it's actually a web page where partners of the project can now go and they can access in an easy to use way our resource database. So they can type in a food service that they need, a county, a zip code, and it'll pull up a list of all the resources available in their area. In addition, we're rolling this out to health systems and partners as sort of a collaborative effort. So this is in a way, a crowdsourced database. So people who have user accounts, which are health system partners and our health department partners, they actually can suggest to us, hey, I know a great resource in Mustang, Oklahoma. And what we found is some of the people that know better what resources work in a small town are people who live in a small town. So we have a really great partnership with 211, but we're also continually developing the system and allowing it to be available to community beneficiaries and to our health system partners. Okay, so I'm gonna move on really quick and talk through some results, and then we'll answer some more questions. So as you can probably see from this graph, we started very slow. On the bottom corner of August of 2018, that's when the go live date of CMS Accountable Health Community Project started. We started in one little clinic in one health system. And as you can see, our growth over the last 3 years has been exponential. As Dr. Pinnick mentioned, this is something that is very easy to scale. So once you get buy-in at a clinic and at an administrative level, we can turn this on for 20 clinics in a health system just as easily as we can turn it on for one clinic. So we kind of had to prove ourselves. We had a slow start, but as you can see over time, we have continued to send more and more screenings month over month. So I'm going to tell you these green mountain peaks. The light green, we measure everyone who opens the screening. When you open the screening, you can see what it's for. We know some people self-select out. They open it and see that it's a social needs screening and that doesn't apply to them. The middle green is everyone who has responded to us. And then the dark green is everyone who reports to us an identified need. And as Dr. Pinnick pointed out, this is uninsured, commercially insured, Medicare and Medicaid. So the CMS project is specifically for Medicare and Medicaid, but MyHealth and our advisory board for AHC decided a long time ago, we needed to make this available to everyone in a clinical setting. So we actually fund the portion to screen commercial and uninsured individuals. So just a few numbers to kind of tell you where we're at. We've sent over 1.3 million offers to screen, which for us is an awesome milestone. We've gotten over 200,000 responses. Over 43,000 people have reported needs back to us that we have sent back to them immediately, a customized resource list based on their home address. So none of the resource lists are generic. They're all based on the patient's home address, which we also pull out of those ADT messages. And then the 70,000 is a little bit confusing because what we find is a lot of people report more than one need. So people that respond sometimes report just one need, but many people report multiple needs. And then the next two items, that's where it gets a little bit confusing. This is where it gets down to just Medicare and Medicaid. So again, you'll remember from the CMS model, Medicare and Medicaid, if they've had 2 ER visits or more in the last 12 months and a social need, they're eligible for these navigation services. We have over 5,000 eligible navigation cases, and we, over the course since August of 2021, have resolved 4,900 social needs as reported by patients. All right. And this was a question someone asked in the chat too. So our delivery rate is currently about 84%. That means about 84% of every message we try to deliver gets through. I will tell you this, so this is project-wide. This is sort of an overview. This is something that is greatly variable based on site. So as you can imagine, ERs, we don't have as great of a delivery rate. In primary care offices, many of those offices, the delivery rate's 98%. We deliver 98% of all the screenings we attempt. The response rate, obviously our sort of method here is we cast a wide net. We offer screening and support to everyone. And then we receive about 18% of all the screenings that are delivered respond back to us. And then from those responses, we are seeing about a 21% rate of social need. This is across the project, regardless of payer class or site. The next slide I'm going to show you kind of breaks that down by payer class. And this is where we think it's really interesting and why we think it's so important that we offer these services not just to Medicare and Medicaid. As you can see, and I'm sure it's not surprising, So the first little box here is overall patient need. So 44% of all people with no insurance report social needs. I'm sure that's not surprising to anyone. 38% of the Medicaid population, 21% of the Medicare, and 17% of our commercial population. I think that's probably the part we were most, I don't know if surprised is the right word. We knew there were needs in the commercial population, but we didn't have a way to measure that previously. And then you can see that the same sort of categories hold true for food, living, utility, transportation, and safety. So these are some of our early results. These are just sort of project overview results. Dr. Pinocchio, maybe we'll stop here and take a few questions about this, and then we can get into the next slide, some new breaking information that David wanted to share. So the percentage of patients who complete the full screening, so that's that response rate is about 18%. We do actually capture partial responses too, because we do know a lot of people do it as far as they want. All the questions in the AHC screening are optional once you get past the qualifying questions. So some people don't fill in the demographic questions that are at the end. What are options for screening without cell phones? So we do have an option. We use SurveyMonkey, an in-person SurveyMonkey tool, where at the clinic, if someone reports that they do not have a cell phone or they need assistance doing the screening, there is an in-person version of the screening too that can either be emailed to the patient or that this clinic can help them to fill it out while they're there at the clinical site. So we do have a way in for patients that don't have cell phones. Although I'll tell you, I think CMS thought we would have a less response rate than we do. I would say 90% of individuals who go into a clinic have a cell phone. It's really amazing. We thought that we would have some more challenges there. In fact, one of the interesting metrics for us is our average age of beneficiary taking the screening is higher than our peers who are doing it in person at an ER or clinic. I think the average age of our beneficiary is about 65. So that tells you that even the older population, who I think we all maybe thought wouldn't be able to be touched by this, is really someone we can still reach through this method. And then, are you screening outpatient clinics? So we screen in outpatient clinics, ERs, hospital units, care coordination sites. I'm trying to think if I've missed any, Dr. Pinocchio.
Well, we've also talked about Meals on Wheels.
We're starting a partnership with Meals on Wheels,
because they're going into homes and doing some screenings. So, I mean, all we need is a trigger to say, this is a person and a phone number, go.
The next question is has your analysis demonstrated that patient response rates and identified need rates have increased correlated to COVID-related unemployment? So, do you want to take a stab at that?
That's a big analysis we have not attempted yet. I will say we're doing a lot of the COVID reporting in Oklahoma, and it's certainly something to be interesting to look at. I think, initial questions to be tackled are, what's it do to utilization of healthcare services? What does it do to cost of healthcare services? And that I'm certain is what Medicare is obviously looking for in their analysis of this data. But one of the interesting things about this is because it comes in on our clinical data feed, we also have these social needs wired back into the medical record as well for the rest of the chart for the patient. So think of all the other things available in a health record, diagnoses, comorbidities, vital signs, medications they're on. And there are a lot of different analyses we could do to look at how social needs travel, let's say, with the other characteristics of a patient's healthcare delivery patterns or characteristics themselves.
And I will say, I think we can sort of make a correlation that needs are higher right now. We have a little bit lower responses, but the same rate of needs. And so that tells us that the people who are responding definitely have needs. We're seeing it in Oklahoma, like in many states, I'm sure you know that there's a moratorium on evictions. So, a lot of things like that we're watching to see how that changes. That ends in Oklahoma in January. So we do feel like some stuff like that will impact our ability to assist people and may increase reported social needs. So some of that still is, yet to be determined. Okay, I'm going to go to the next slide. Dr. Koenig, I think you wanted to talk about sort of this late breaking.
Oh yeah, so the new E&M coding guidelines are out, of course, for this year, and I happened to be in the room, and my wife was studying it for her practice, and it came up that there's been some major change, probably the most significant changes since like the 1995 timeframe to these processes, and it turns out that now if you detect and report a social need on a patient, that's grounds for upcoding a whole level in your billing. And I don't know this in great detail, but it's new enough news that I wanted to get it out there because it could certainly impact our ability to motivate healthcare delivery systems to add this to their usual course of care, because it's as significant as adding an additional diagnosis or adding an additional procedure to the visit. And FYI for my colleagues in health information exchanges, it also appears that the providers also get credit for accessing outside records and reviewing those in the billing process as well. So that was basically the message I wanted to get out there is even without the AHC project being done, looks like CMS is folks are doubling down on social needs, and we've got to get it in the workflow in an effective way. I guess I would also say really am totally impressed by the work in Idaho, and of course our friends at the Health Collaborative. It's always hard to follow in presentations, especially with the closed loop referral work. I've done a lot of research on that in my early years, and it's so critical, important. We have not yet hooked this process up to closed loop referral, although we can see if the patient has visited the link, but that's as far as ours goes right now. Our plans are to hook it into a closed loop referral process as a next step, but we do feel like this is a pretty good scalable workflow that organizations can adopt quickly.
And there was a question about how have CBOs responded to screening and referrals. I think we're facing the same challenges everyone is. One of the things we spend a lot of time on is, especially with our navigators, trying to make sure that we know what hours are food banks holding now? What are the new requirements or restrictions? I think the world of COVID had changed things so much in the CBO world that part of why we built this sort of public-facing community resource inventory is it's hard to keep up with, is Catholic Charities accepting new members now or not? Are there new requirements? Are there new documents? And so I would say because we're statewide too, we obviously don't have a hands on every single CBO refer to everyone too, but we have great partnerships through our advisory board that include the food banks and the United Way. And so we're all working together to make sure that sort of trends and gaps that we identify through this project are shared at the community level. One of the requirements for the AHC model for this alignment track, which is what we are, is that every year we do a health-related equity study for our geographic area and our beneficiaries, and we also do a gap analysis. And the gap analysis is really what is missing in terms of how do we meet beneficiaries' needs, what resources do we need, and then those results are discussed, and we pick an area to then focus our quality improvement on for the next year. And so, for example, we saw a spike in needs from maternal health clinics, women who were under 40 who were being seen at either OBGYN or any kind of sort of maternal health location. We saw a much higher rate of need coming out of those populations. And so we are working to make sure we have we have resources to provide specifically to those populations. And that's work, obviously, we're not doing alone. We're working with our domestic violence agencies in Oklahoma and food pantries. And so part of what this work brings up for us is how do we share what we're learning? And that's, we're getting ready to go into year 5. And, here in Oklahoma, we hope to continue this work beyond the CMS project and the CMS funding. And so part of that is within our community, our philanthropic and health system partners, how do we keep the work going? We've learned a lot about using community health workers as a cost-effective and well-received method of supporting patients. We found that a lot of beneficiaries open up to community health workers, that they might not share things with their, provider, their doctor. And so we're really looking at what is the next step. And so part of what we're learning in terms of gaps and where do we fill in, we're sharing that with our community. And so I think that's where we go from here, right? Is how do we work on this together, and how do we not let this work? I'm sure our friends who are also in the AHC group, we've put a lot of work into this for the last 4 years. And so we want to continue this. And we have a lot of interest from partners and just trying to figure out, how do we keep this good work going that CMS has started and kick the ball down the road, and how do we continue from here? Dr. Kinnock, anything else? I think that's really sort of the gist of what we wanted to cover today. Anyone else have questions? We're happy to answer anything. If someone asked about the link to this coding change, we can share that.
Yeah, if you wouldn't mind, post that. I would say for the group, we're seeing your screen, by the way.
Sorry.
For the, I want to call out kudos to Jennifer and her team, whose names you see on the screen there. I mean, they've just done a phenomenal job of taking something from an idea and, dealt with all the technical challenges and bugs and things that have to be worked out to make something that's pretty close to a real-time process function in a practical clinical setting. And you know how varied the clinical settings can be, how many different personalities you're dealing with, and to have really gone from, I would say we were probably the worst AHC at the beginning, because we just had such low volumes. We were iterating quickly to try and wring out the bugs, but that effort has paid off and was no clearer than in the curves post-COVID, when we really didn't have much of a drop-off in our ability to screen and get to patients, especially at a time when they needed it most. So yeah, there you go. There's the team, and they're all fantastic.
Yeah, and we're happy to share any more information. You're welcome to reach out to us anytime. I did post the link, the late-breaking link to the EM coding guidelines in the chat too.
Thank you. Thanks. This is Lisa. Thanks, Jennifer and David, for really wonderful presentation. A very exciting tool. It's really great to see how it's developed. Jennifer was very generous previously and did a presentation for us now a year and a half ago, I think. It's a very early point in the development. Are there further questions for David or Jennifer? So since we have a few minutes available to us, I wanted to know if it was, I'd like to sort of generate a little bit of discussion around how people are looking at these exciting and really important programs and how they can be, as the question Jennifer just posed to us, sustained over time when you're no longer in under the umbrella of the Innovation Center or some other program that's has some structure to it in terms of funding. And then even beyond that, sustainability, how does it spread? One of the things that in Oklahoma, I mean, I know that they're through the CPC Plus and other regional collaborations, there's a lot of work that's shared between Kansas City and Arkansas and Oklahoma. It's just been an interesting triad that's developed over the last couple of years. I'm sure there's a great deal of interest in those places, and if you can see some sort of a potential rollout in other places that might have, given that the borders are porous and you have some contiguous care of patients in those states and regions, or the broader picture, how does this get not packaged and rolled out, but like how do we share this more locally? We've got a lot of very activated regions on the line and states on the line with us today. So I just wonder how you see that. Either Jennifer, David, or others on the line want to address that.
Well, I'll take a stab at it. I know that certainly our health plan partners have been interested in the fact that we've screened huge numbers of their members and have that data attached to their medical records and so on in our systems. And so we think that group is a good opportunity for a sustainability, to help with the sustainability model here. Then in terms of scaling to other geographies, I mean, the input stream for what we're doing is an ADT message. As you know, the communities the conditions of participation requirements with the new interoperability law rules from Medicare do require that hospitals be routing ADT messages either directly or through a partner to primary care and long-term care for those patients. So more and more ADT feed data will begin to get mobilized. And I think that every time that happens, that's an opportunity to use the tools that we put together for this.
Hey, David, it's Dick Shonk, and a great presentation, and also the folks from Idaho. I didn't chat in about that, but very impressive work going on everywhere. Kind of to my previous point, and you just mentioned the payers and their uptake on this. Have you guys seen any impact on closing gaps in care and that impact upon star ratings? Has that come up in your neighborhood?
No, that's one of the big questions I'm dying to ask of the system.
Okay.
We, you know, as do you guys, we also get the claims data. We're the data aggregators for CPC Plus in our region, and so we really want to take a look at the cross-reference between those patients' utilization and cost, and as well as care gaps, and what's going on with their social needs.
Yeah, I just think it's a good ROI for the payers if they can actually do that. It really gets their attention, I think so.
Yeah, it's analysis we have to do for sure.
Great. Any other questions or comments? It's been a really great afternoon here. I just want to thank our speakers once again mostly for the work that you do on behalf of the citizens of your states and regions, but also for sharing your expertise with us today.